something that's changed in my career. When I started practicing medicine, there were some nurse practitioners, but not many APPs at Mass General. And it's such a treat and pleasure today to introduce two very talented and important nurse practitioners who are leaders in our neurofibromatosis and schwannomatosis communities. Christina Orr, who works with us at Mass General Brigham, and Courtney Lewis, who works at Boston Children's Hospital. I try not to get too defensive because a lot of my patients say, well, I'd rather see Christina than you, Scott. So, I mean, it is a little destabilizing. Having said that, she's a wonderful partner, and we're going to start by hearing Christina Orr speak about the role of advanced practice providers, APPs, in caring for patients with NF1 and schwannomatosis.
Okay. Good morning, or good afternoon. I practice my talk by saying good morning because this is usually in the morning, but good afternoon, everyone. I'm really excited to talk to you. Okay, I'm going to slow down. I'm a little nervous. But with so many familiar faces in the audience, I know I should be more comfortable. So I'm going to start out by doing an overview of the role of the advanced practice provider in the NF and schwannomatosis clinic, and then Courtney's going to get into a little bit more specifics of our day-to-day roles. Okay, so first, what is an advanced practice provider? A lot of people haven't heard this term, but it's an umbrella term to describe nurse practitioners and physician assistants. And really for the purposes of this discussion and in practice, NPs and physician assistants are equal. So I liked this definition from the NCI. It's they call us a medical professional who are not doctors, but we have specialized training licensed to diagnose, treat, and manage many common medical conditions. And we can also perform physical exams, order lab tests, imaging tests, review results, prescribe medication, perform procedures, and make referrals. But more practically, what can an APP do? So we function both independently and jointly with physicians, which we think of as shared patient care. So I see patients on my own schedule, and I also jump into visits with the physician, and I'll pull them into visits with me as well. And so we really think of it as a nice team model together. We're able to prescribe, so that's both day-to-day medications like blood pressure medications or neuropathic pain medications, but we also can prescribe chemotherapy like MEK inhibitors, brigatinib, and bevacizumab. We're good at symptom management, so if you're coming in with a problem or having a side effect from a medication, we're good at teasing that out and trying to figure out what's going on and how to improve that symptom. And then we can assess patients and assist in making treatment decisions. Sorry, this is a little bit cut off at the bottom. And so I think of the roles of the doctor and the APP as very complementary. So APPs have diverse career paths with different experiences before their current role in the clinic. So many NPs, like myself, have experience as a nurse before becoming a nurse practitioner. And we follow sort of a holistic model of patient care. Physician assistants also have lots of different experiences prior to their current role. A lot have worked as medical assistants and EMTs, and they have more training in the medical model. So I think of us as sharing some roles with nursing and some with the physician. And then the doctors have more training in a biopsychosocial model of patient care, and they're really the leaders of the diagnostic workup, and they determine the treatment plan. And so this is just a comparison. I'm going to focus here on the middle. And again, a little bit's cut off at the bottom, but comparing the roles of the physician, the APP, and the RNs. So the physician, as I mentioned, is sort of the leader of the diagnostic workup and determining the treatment plan. But we as APPs get to know you as patients, and we help with that decision-making as well. We can both prescribe and order. And we all do some degree of triaging. So triaging means if you're calling into the clinic and you're having some sort of pain and you need help figuring it out, we all can help you figure that out, whether that's over the phone or having you come into the clinic. The reason I have some under the physician category is because their time outside of the clinic is busy with research and teaching and advocacy. And so we tend to be their boots on the ground day to day in the clinic. So a lot of times you'll have more exposure to us as the APPs or the RNs to help figure out any urgent issues that are going on. We all do some care coordination between other specialties. We all do some chemotherapy counseling, again, some under the physician category just because of some time limitations. We have a lot of time that we can spend with you guys. And then we all do family support. And then what's cut off at the bottom is side effect management. A little bit limited on the RN side because they aren't able to prescribe. And then I'd like to show an example of how the physicians and APPs both lead at different times and in different ways. So the blue sections are going to be led by the physician and the green will be APP. So let's say you come into the clinic and you are diagnosed by the physician with NF or schwannomatosis. The doctor is then going to evaluate your level of disease burden and decide when it's the right time to intervene. And they're the ones that determine the treatment plan. And so let's pretend this time it's a medication rather than a referral to surgery. So then they hand the baton over to us as the APPs. And if this is a medication like brigatinib or a MEK inhibitor, we first work on insurance approval to make sure that we're able to prescribe without any issue. We then will educate the patient and the family about the medication and we'll prescribe it. And then we'll monitor and manage side effects. We then hand the baton back over to the physician when it becomes time to evaluate for the treatment response, especially if that's with an MRI scan. That's always a physician visit. And then if you're going to stay on treatment, they'll hand the baton back to us and we'll continue management. And so we sort of doing this seesawing back and forth. But again, you can see sort of with the mixed colors, it shows that we work back and forth together and we're almost in constant communication. And then finally, I just want to go over some common visits that you might have with an APP if you're not familiar yet. So if you're someone who sees us annually, you might start seeing an APP. Oop, I don't need the pointer. Sorry. You might be seeing an APP, especially if that doesn't involve an MRI scan. We can do these annual visits for you. A problem-based visit would be if you called in having pain or a bothersome tumor, we would have you come in, let us evaluate you. We can have the physician jump in or, talk to them after the visit and help figure those things out. And then chemotherapy visits are the bulk of what we do with the NF and schwannomatosis patients. So a new medication start like brigatinib or MEK inhibitor, monitoring while on chemotherapy, and then infusion visits. If you're someone who comes in for Avastin infusions, you usually see me or one of the other APPs prior to starting that. And then finally, if you're a patient on a clinical trial, for example, our Starfish trial, you'll see me on a regular basis prior to those treatments. So now I will hand it over to Courtney.
Good morning, I'm Courtney Lewis. I'm the nurse practitioner within the neurology NF1 clinic at Boston Children's Hospital. Yeah. So Christina gave a great overview on the role of the nurse practitioner, so I'm not going to spend too much time on that. I'm going to talk more about my biggest role within the neurofibromatosis clinic at Boston Children's Hospital, which is to help co-manage our MEK inhibitor clinic. So the way that our clinic, our NF1 clinic in neurology at Children's is structured, we have two attending. So there's Dr. Ulrich, whom you know, and Dr. Benitez, who's going to be speaking later, myself, the nurse practitioner. We have a clinic nurse, Haley, who is excellent. She's our triage. We have a school liaison, educational specialist, Meredith Chambers, who's going to speak later as well, and then a research assistant and a patient coordinator. So as you might know, NF1 mutations cause some oversignaling of the RAS signaling pathway, which can lead to cell proliferation, overgrowth, plexiform neurofibromas. So MEK inhibitors block the protein that causes the cellular proliferation with the goal of helping unwanted cellular proliferation to try to stabilize the plexiform neurofibroma and hopefully shrink it. So there are different types of MEK inhibitors. There's trametinib, which comes in liquid. There's selumetinib, which is FDA approved. It was FDA approved in 2020. Mirdametinib, which is the more newly FDA-approved medication. It comes in a dispersible tablet. There's cabozantinib, binimetinib. So in order to determine which medication is right for a specific person, we have to take into consideration the availability. So some of our international patients aren't able to get the medication back home. They can only get one type or one specific medication. We need to know if somebody can swallow pills or not swallow pills. And also, if somebody's been on a MEK inhibitor before and had side effects, that doesn't necessarily mean that they won't do well on another MEK inhibitor. So we look at the side effect profile as well. So with more patients starting on MEK inhibitors, we're also seeing more patients continuing on therapy long term. So when we start somebody on a MEK inhibitor, we have the tentative duration of treatment to be about 2 years, pending they're doing well and having response. But now with more data, we're seeing patients stay on longer past the 2-year mark. So one of the biggest side effects with these medications is the skin. So we see a lot of rash, mainly acne on the face, the chest, the back, some dry skin like eczema, and then paronychia, some nail bed inflammation. We see nausea, vomiting, diarrhea, low appetite, fatigue, which can be multifactorial, infections, although this is not an immunosuppressive medication. More rarely, we see some changes in the strength of the heart pumping and also the heart conduction. We see some changes to the blood vessels within the eye. So we have them follow up closely with the eye doctor and then also get echo EKGs to monitor the heart. We see some liver toxicity, muscle pains, check labs, peripheral neuropathy, high blood sugars, hematologic issues. So we closely follow and monitor for these side effects. So the best way to manage the side effects is to get ahead of it from the beginning. So when we start a medication, we try to have them follow with a dermatology clinic right from the onset to try to get ahead of some of the side effects. So we plug them in with dermatology, and we also have a pretty good skincare regimen. So we have some topical antibiotics and some oral antibiotics if needed, bleach baths. And we also connect with the podiatrist if we have like refractory paronychia and nail bed inflammation. We also will consult with cardiology to determine if we need to adjust the dose of the medication or also adjust the monitoring intervals or even do a drug holiday if they're really affected. Again, with more patients being on these medications more long-term, we want them to have few side effects so that they tolerate these medications and have good compliance. So we try to dose adjust with any persistent side effects. So in terms of monitoring while one's on these medications, we image every 4 months for the first year and then every 6 months thereafter. The response typically takes by imaging about 8 months to see, though we do see some symptom improvement earlier on. We follow the eye exam closely because of a rare side effect of some side effects with the vessels in the eye. So again, we see them every 4 months for the first year, ophtho every 4 months for the first year, and then every 6 months thereafter. And same with the echo EKG to follow the heart. We do labs every month while one starts these medications just to make sure everything is nice and stable. If everything looks okay, then we shift it to every 2 months. And then for the first year, we like to see them in clinic every month to look for side effects, make sure the patients are tolerating the medication. And then if everything is going okay after 1 year, we switch to every 2 years. So this is just a table that our research assistant, Olivia, created that helps keep track of the surveillance for the different patients on MEK inhibitors. There's many patients now on MEK inhibitors, and there's a lot of surveillance. So this kind of keeps it all together nicely. And then again, this is my biggest contribution within our NF1 clinic at Children's. So like I said before, I co-manage patients on MEK inhibitors with the attending. We'll schedule a visit with me to see the patients monthly to check in, and then the attending will check in with every scan just to go over, review the imaging and talk about next steps, if we need to make any adjustments. Everybody's available for questions, follow-ups. We also consult with the attending for any persistent side effects and reevaluation at the 2-year mark to see if somebody should continue on more long-term, if we give them just like a lower dose to continue on indefinitely. And then also when somebody's ready to go back home, if they're from abroad, when they safely can repatriate. So I will also consult with dermatology, ophtho, cardiology, and we really try to have good comprehensive care for these patients on MEK inhibitors. So thank you for your time. Thanks to all of our patients and families.